Yeah. One is you want to establish the diagnosis and the severity of the respiratory. If somebody is having difficulty in breathing, you want to know what is the problem. Is it the carbon dioxide, or is it the oxygen which is failing, or what is causing? Then also you want to know what is the respiratory failure, or is it a cardiac dysfunction? Is it a renal or hepatic? Is it a polytrauma or a diabetic ketoacidosis? In sepsis and in shock and in poisoning, many times there are so many indications to do an ABG to correctly see whether it is a type 1, type 2 or a mixed failure. So looking at those, you can always understand what is the type of failure and then go to the history and also the other things, thereby knowing what could be the problem. Next. So it also can guide the therapy in the ICU. Oxygen, should we give the oxygen? Should we go on to a CPAP or a BiPAP? Or can we go on to a mechanical ventilation? Or does he require an alkali treatment? And monitor the patient during the mechanical ventilation, cardiopulmonary bypass, and when you're doing sleep studies, all these things we can. And determine also the prognosis in the critically ill patients. Suppose if you see a patient who has an ARDS, and when he came, he was in a severe ARDS. What does it mean? Less than 100 PO to FiO2 ratio. So that is, we call it as severe ARDS. Suppose we put the patient on a low tidal volume and then we prone all that, then we understand whether the FPF ratio is improving. That is also to guiding the way we have to ventilate, when to go on ECMO. All these things are important for us. Next. So one, to know the blood gas is to detect presence and severity of hypoxemia or hypercapnia, changes in the acid base, which might need further investigation or any intervention. Okay, this one is the main thing why we do an ABG. Next. So these are the normal values which all of you know. I don't have to say these things. pH and PCO2 and PO2, these are all the normal. What is the base excess, oxygen saturation, content. Content and oxygen saturation, little bit I would like to tell you here. Saturation is the amount which is taken up by the hemoglobin, the percentage taken up by the hemoglobin. Content is the amount dissolved in the oxygen in the plasma. So these are the two things. So when you mix these two things, this is called if your oxygen is given to a higher level also, the saturation does not greatly increase above 97 or 100. So that is carried by the hemoglobin. Content can be, so combined, put together, the saturation usually, the capacity it can hold, and the saturation is usually by content by capacity into 100 is usually referred to as saturation of the hemoglobin. So that capacity by content multiplied by 100 is the saturation. So sometimes, so the different alveolar and the other one, and alveolar DO2, if it is usually about 10 to 15, if it keeps on increasing or decreasing, what is the problem? Will come later. Next slide. Yeah. So now you know there are two things. One is which are there in the body, and these were called the hydrogen ions, which are acidic, and OH ions or alkali. So these are the various things one has to remember. So pH, when it go on decreasing, what will happen? The H ions will increase. And when the pH is increasing, the OH ions will increase. So that is how you usually, so at 7.4, if that is your this thing, then what you have is 40 nano this thing of the H ions are there in the nanomoles of H ions. So these are like, however, if the pH is increasing, the H will decrease. So alkalosis will decrease. Alkalosis will increase, and acidosis will decrease the H ions. That is how, if you remember, that's more than enough for you to understand and then get on with it. Next. So what are the, it is important is asked in the exam. Usually we measure pH by the electrode and the pO2. And the other one which is measured is the barometric pressure, which is that if we are having it, then it will say 760. Really, the water, and then all the rest of the variables, what we get there is all calculated from various things. Okay, from the PCO2 and the pH, we get the base excess, all those things. From the hemoglobin, we get the saturation, all those things. So only 3 variables are measured in the pH meter. And these are pH, PCO2, and PO2. And of course, the barometric pressure will be shown next. So, please.
Ma'am, can you see this slide?
And now I can see better. What was the last slide before this? Before this?
Before the slide, ma'am. This is the before.
Because I think we have missed some. Next to this. Yeah. Okay, that's fine. Yeah. So before we, what are the steps? No. Keep that one. Why are you changing the previous one? Yeah, that's it. So what are the steps to acid-base analysis? Most important, you should know that there is a little comprehensive history and physical examination. If there is a patient who is a known asthmatic or a known COPD, is a smoker, so what do you expect? Is CO2 will be higher and PO2 will be lower. So that is why when you look for it, you will be. Then when you do that, you also order the electrolytes and the chemistry so that it gives you a better idea. And first of all, we have to know what is the primary disorder. Is it respiratory or is it, and what are the various compensatory mechanisms, the expected condition, and also calculate the gaps. So this is the basically the steps to acid base. One, history and examination. Second, ABG and chemistry, means electrolytes. Identify the primary disturbance and then see whether it is compensated and how we compensated and calculate the gaps. Once you calculate the gaps, you can see any mixed acid-base disorders.